Welcome to the U.S. Healthcare System Lecture Series by Monika Wahi, based on Essentials of the U.S. Healthcare System by Shi and Singh. Welcome to the second lecture over the second half of Chapter 8. In this lecture, we will get more into the different characteristics of hospitals. Can you categorize your favorite hospital? Chapter 8, Hospitals, second half. Learning objectives. At the end of this lecture, the student should be able to describe at least two ways to classify hospitals into types, to name a real hospital and know how to classify it into a type of hospital, describe one way a nonprofit hospital is different from a for-profit hospital, and to be able to give an example of a specialty hospital. Let's continue with our discussion of hospitals with classifying them into different types. As you will see by the slide, there are many and possibly confusing or possibly contradictory labels you can put on a hospital. They all mean certain things. And so therefore, we're going to go through these different attributes of hospitals and try to see how the ontology of classifying hospitals works. We will start with private for-profit hospitals and private nonprofit hospitals. On this slide are examples local to me in Boston of private nonprofit hospital and a private for-profit hospital. As you can see at the top, there's Children's Hospital. This is a private nonprofit hospital. Nonprofits are also called voluntary hospitals. This is operated by community organizations, philanthropic foundations, fraternal orders, and societies. They often include the church-owned hospitals, the Catholic, Protestant, Jewish hospitals. And their nonprofit status is for a tax break because they benefit the community. And so please understand what they do is they don't have to pay taxes to the state government for being a corporation because they are seen as benefiting the community. They're nonprofits, so technically a nonprofit can't take profit and give it back to their stakeholders like corporations like, Microsoft would do. A nonprofit has to take that money and they don't have any shareholders, they don't have any stock. Their community is their stock. So basically they have to take their profits and put them back into their organization. So if for some reason Children's Hospital just makes a lot of money extra above and beyond their costs, it's maybe not such a bad thing because then Children's Hospital will invest in themselves, and that's wonderful. Private for-profit hospitals are proprietary hospitals, not voluntary hospitals. And they have stockholders and investors like I was just describing with regular corporations, right? And so there's no nonprofit tax break for them. They're a for-profit entity, and so they're trying to make profits. So they give the profits to the shareholders, and they're not forced to invest them into a hospital. And so this hospital here is next door to Library College. It's Kearney Hospital. It's owned by the Seward Healthcare System, and that is a private health system. So a lot of people ask, are nonprofit hospitals in any way better than private for-profit hospitals, right? Because it sounds like they are. Like nonprofits have to invest in themselves, thus invest in the community, whereas private for-profit hospitals just give the extra money that they make to their stakeholders. Well, let's just be realistic here. Nobody's making a lot of money, I don't think, in healthcare. Have you noticed? Nonprofits compete head-on with private hospitals. Okay, so those two hospitals that I showed you on that slide, they're miles from each other. One is a children's hospital, right? But the other one treats both children and adults. And so there are children that could go to either. There are a lot of probably providers that have either worked at both those hospitals or maybe go back and forth. So not only do those two hospitals maybe have the same patients and the same providers, but they certainly take the same insurances. I know Children's and Kearney Hospital are going to have to take certain insurances we have here in Massachusetts, and so they're really similar in those ways. Both hospitals, types of hospitals in general, I can't speak specifically to these two, but whether you're nonprofit or you're for-profit, You can't tell by the marketplace behaviors. I mean, if you just think of what hospitals you've seen advertised in your community, just because they're advertised doesn't mean they're necessarily for profit. They might be nonprofit. I mean, even the nonprofits need patients or else they can't invest in themselves. And both provide similar levels of charity and uncompensated care. Now, that's kind of this myth that people have in the US that nonprofits treat people for free a lot more. They actually don't. For profits and nonprofits treat people for free at the same level. So I'm taking a quote out of the book when I say, hence, whether nonprofit hospitals are indeed charitable institutions then remains controversial. Let's get back to our busy slide of all the different types of hospitals, but let's then clear the air and just focus on general versus specialty hospitals. Here are local examples to me. On the top is Massachusetts General Hospital, hence the name. And below is McLean Hospital, a very old hospital in Belmont, Massachusetts, that's a psychiatric hospital. This was a hospital that, if you know about poetry, Sylvia Plath was in once. Unfortunately, she killed herself. I don't think she was at McLean when that happened. But anyway, we've always had problems with our healthcare system, even back in Sylvia Plath's time. But in any case, this is a very historic hospital, but it's a great example of a specialty hospital. But let's go up to the top of the slide and first talk about general hospitals. Most hospitals in the US are general hospitals, and so it becomes kind of difficult to explain what they are because it seems like almost all of them are. They provide diagnosis, treatment, and surgical services for acute medical conditions. Well, that just sounds like every hospital, right? General does not mean it's less specialized or there's inferior care. I know when people are psychiatrically hospitalized at Massachusetts General, they get pretty good care. And so, what's the difference between Massachusetts General then and McLean? Well, McLean only offers psychiatric care. They're not a general hospital, they're specialty. So basically, that's why when you think of hospitals, almost all the ones that will come to mind are general hospitals. There aren't as many specialty hospitals, and they're only in certain categories. Like that children's hospitals I just showed you is not a general hospital. That's a specialty hospital. If you see a rehabilitation hospital, then you will see that that's a specialty hospital. So you see the difference. So let's talk about the three big types of specialty hospitals. There's a few little odd ones like the tuberculosis ones, but we don't have a lot of tuberculosis now, thank goodness. But we have, unfortunately, psych, rehab, and children's issues still to worry about. So let's start with psych. A psychiatric specialty hospital provides diagnosis and treatment for mental illness. So therefore, when you think about it, remember how hospitals in my last lecture have all these obligations and regulations and you name it, Asians? Okay, well, all of that says they have to have psychiatry, they have to have psychology, they have to have social work. It makes perfect sense for a psychiatric specialty hospital, right? What's also interesting that I didn't really think about is they have to have an agreement with a general hospital, because imagine somebody becomes so ill or so injured at the psychiatric hospital they can't really treat them there, right? From many things that a general hospital treats them for. So originally, state governments set up psychiatric hospitals, but now private hospitals and outpatient treatment centers deliver the most of the care that goes to mental health patients. And so that's why at most people in the U.S. who are psychiatrically hospitalized will end up being in some sort of general hospital's psychiatric section. Less often will they actually be in something like McLean. Let's move on to rehabilitation specialty hospitals. Now, when they have to meet their requirements, they're looking at a different set of requirements, right? So they specialize in therapy to restore the maximum level of patients who suffered a recent illness or accident. So even if somebody has just had their breast removed because they had breast cancer, that's really difficult to come back from. And so this could help rehab somebody from that kind of an operation. So there can be no cure sometimes. In fact, sometimes you have a situation where this person will never be restored to full function, but rehabilitation hospitals can improve function. And so after trauma care or procedures at general hospitals, people sometimes are sent to a rehab hospital. In fact, that happened to my friend who got hit by a car. After she was in the hospital for a while, she was sent to a rehabilitation hospital. And so This kind of a hospital has physical, occupational, speech, and language therapy. Makes sense because that's what they're doing. Finally, we get to children's hospitals. And so these are community hospitals with special facilities for children, especially rare and complex conditions. So 75% of the children's hospitals patients are actually being treated for chronic or congenital conditions. So you'll see most children are actually treated at general hospitals, especially, I mean, think of your kid falls out of the tree, you're going to run off to Mass General if you're down the street from it, and probably they'll be just fine taking care of your kid. But if your kid has a congenital condition, unfortunately, probably children's hospitals is where you want to be. Other patients that are not in that 75% require intensive care for other things like transplants or cancer treatment. And children's hospitals require a higher nurse to patient staffing ratio. So right there you can see that pediatric nursing has to be sort of a big field because there needs to be a higher staffing ratio. So we return to our busy slide, and now we are going to focus on, even though I've been throwing these words around in this lecture so far, I haven't defined them yet. Well, let's look at them. Community versus public. Now, it's actually not fair to say community versus public because all community hospitals are also public hospitals. And all public means is everybody from the public can go there, right? So I'm going to talk about community hospitals being public hospitals. They're open to the general public, as you see in the lower left. But here's some other things about them. Is that they're not federal. Okay, so there's nothing federal about any of these community hospitals. And so they're operated by state and local governments. That's why they follow these state and local regulations. They are short stay hospitals, so average is less than 25 days. So this is not like if you are a person who lives in a group home, that's like a long stay setting, like a long term setting. This is the short term setting, okay? Now, if you look in the upper left-hand corner, you'll see that community hospitals can either be private, for-profit, or non-profit, right? They can either be general or specialty, but as you can imagine, they're probably going to be general hospitals, right? Because there's just more of those. However, getting back to the public part, it's easier maybe to think about public hospitals just in one sense from a federal standpoint because most of the federal hospitals are not public hospitals. The VA is a great example. It's not public, like you can't just go there, you have to be a veteran. Same with the Native American hospitals, which we don't actually hear much about in Massachusetts, but where I'm from in Minnesota, the Indian Health Service infrastructure is very important, and those are national hospitals, and they're not public. You have to be Native American or somehow qualify to use their services. On the left side of the slide, you see that 85% of all U.S. hospitals are classified as community hospitals. So this is about community. Those are non-federal, and they're available to the general public, and they have an average of less than 25-day stay. So they're not the VA or military treatment facilities. They're not hospital units in some institutions like prisons or universities, because those are not available to the public, right? And then most hospitals are operated by local governments in the community. The rest tend to be long stay, right? So psychiatric or this tuberculosis, chronic disease. So public hospitals can be affiliated with medical schools, and they can be financed by Medicare and Medicaid and state and local taxes to train the people who are in those who are doing medical care. So why do we have these? Usually in large urban areas for inner city people, there's a lot of indigent and disadvantaged populations. So you need to have public and community hospitals. You need to have hospitals serving the public that are community hospitals. And as I showed you in previous slides and slides from previous lectures, the poor health status and also high violence that can happen in this population, the high levels of stress that come with low income, etc., these hospitals have a high utilization. And remember what I had said about how big they are. The average for community hospitals is 115 beds, but large ones that are affiliated with med schools and funded by federal and local funds, they can serve more people. And so I know the University of Minnesota gives a substantial amount of charity care, their medical system. They have a big medical school, and so you end up with these big infrastructures that can give a lot of charity care. but unfortunately have a high level of utilization by the people who maybe need the charity care, right? And so, due to financial pressure, many of these kinds of hospitals, as you can see, this equation is not going to keep adding up. Many are privatizing, like they're kind of going a different direction, or they're just closing. The number of community hospitals went from 1,444 in 1990 to like losing, like if you think about it, that's almost, if you round up to 1,500 and then you round the next one in 2009 down to 1,000, that's like a third of the hospitals. Like that's a lot that closed. So finally, we're back with the last three things to look at. There's teaching hospital, osteopathic, and rural. I can't focus enough on the issues rural areas have with different challenges in the healthcare system. If you're not in an MSA, which is a census area that includes a city with 50,000 people or more, or it's in a total, there's a total MSA nearby with 100,000 people. But basically, it's pretty easy to not be in an MSA. Is like I'm in Boston. Boston's kind of radiates out, and so it's a big MSA. But a lot of Illinois, for example, a lot of Minnesota is not in any sort of MSA, even where there are bigger cities. These areas have a higher percentage of poor and elder patients, and remember, those are the people who really need the health care. And it's really a challenge being out in a remote area, having a small size, having a limited workforce. There are physician shortages, and a lack of financial resources make it all the harder to deliver health care to rural areas. So, as part of that, we have an important component of our U.S. healthcare system, which is the critical access hospitals. These were to prevent small rural hospitals from having to close as part of that big change with prospective reimbursement. Now, I love to laugh about that. What a big moral hazard that was. On the other hand, sometimes you need to take on a little bit of moral hazard because even though Hill Burton maybe overexpanded our hospitals, it really did help critical access hospitals get situated. So why turn them off just because we're doing this now retrospective reimbursement and we're realizing that they're in market failure because it's just expensive to deliver this care in a remote area. That's just a fact. We need them to continue whether or not they're for profit. Again, the government stuff happening here, which is the Balanced Budget Act of 1997, which allowed designating certain rural areas critical access hospitals, but you can't just go to town with it. Cannot have more than 25 beds, 24-hour emergency service, and an additional 10 beds may be in operation for psych or rehab. So it's kind of like emergency room light complete with psych or rehab, right? And again, this is reimbursed on retrospective reimbursement because they simply wouldn't stay alive otherwise. Now we move on to teaching hospitals. That was the other one of the other remaining bubbles. So a teaching hospital, they are classified into two different kinds, major and minor, and the major ones can move on and establish academic medical center. So let's just start with the yellow area where just being a teaching hospital means you offer one or more graduate residency programs offered by the American Medical Association. So it doesn't really matter who's training there. It's not a teaching hospital unless physicians are training there. Again, a reflection of the AMA's power. So the primary role of something designated as a teaching hospital is to train physicians. So if other people are getting trained there, that's nice, but this is the purpose of the teaching hospital. Now let's look at the big major hospital, the blue section, dark blue. Major teaching hospitals offer residencies in at least general medicine, surgery, OBGYN, and pediatrics. These are that general practitioner category I'm talking about. That is not specialty. Of course, let's say you want to be a hand surgeon, you have to go through that training and then do fellowships. But this is your basic stuff. So often there are many other common residencies offered in addition to these, like pathology or anesthesiology. Obviously, you need anesthesiology if you're doing surgery. And sometimes they offer subspecialties like blood banking and pathology. And so that's where a general pathologist might go on and specialize. Minor teaching hospitals mainly offer specialty residencies. So I don't know. Oh, yeah, I do know. McLean Hospital is a teaching hospital for Harvard University. I don't know the specifics, but I imagine if you go to Harvard Medical School, you would be able to rotate over there. Just because I remember seeing a lot of advertisements for the fact that they do clinical research over there, and it's been affiliated at Harvard for a long time. And so I have had friends going through medical school who have been very excited because they get a special sleep disorder rotation or addiction medicine rotation at a minor teaching hospital. Finally, you got these big academic medical centers. That's where sometimes people like me, public health people, get trained. Some major teaching hospitals are affiliated with medical schools and universities, and when there's active collaboration between the university, its med school, the hospital health system, and healthcare professionals of all kinds, you can really get this powerful academic health center. At the University of Minnesota, I haven't checked in recently, but when I was actually studying there, you had the academic health center being the medical school, the school of public health, and the school of nursing, this trifecta of power. And something like that is at the University of South Florida too, although there's a college of public health there, and I'm forgetting whether it's nursing or exactly how that's put together. But there you can really have a lot of teaching power. So why be an AMC? Exactly the reason I just said, teaching power, uniquely capable of conducting not only basic research, right, in the laboratory, but applied clinical research. Same oncologist who's in the lab experimenting on animals and dealing with petri dishes can be running out there and giving these treatments to his or her patients. Awesome. Well, also they provide healthcare services and they offer medical education. I mean, what could be better? There's a special role of teaching hospitals. They have a special mission. Not only are they teaching, but what comes with teaching is research, right? Like I wouldn't be very good of a lecturer if I didn't just do research all the time, right? Because I know what's hot. It's boring to listen to what's old. And then specialized care, right? Somewhere in the United States has to be the incubators of what do you do about these rare diseases? And so you need a place where all the rare disease people collect so they can really think about it. Complex medical problems often require the latest medical technology. Well, where should we all put that? How about with some of the smartest people who have some young people training and we can all work on it? And then also in the specialty of certain professionals and certain services, you really only get to study at teaching hospitals because teaching hospitals are the only places that offer these services to patients. It can be very powerful. Like if you study the Minneapolis-St. Paul area and you see the role of the University of Minnesota in terms of this role, you will find that people from all over Minnesota will come to the university. I haven't even mentioned the Mayo Clinic, but they will come to the university for these specialty professionals and services, even if they live in the rural area, because this is the only place they are, and then it's easy to study, right? And so many specialties and subspecialties are represented, and a great example is the University of Minnesota does a lot of transplant. They're really good at that. So if you're in Minnesota, and it doesn't really matter where you are, it's likely if you need a transplant, you'll be going to the university. The textbook talks a lot about osteopathic hospitals. I'm not sure why they do that because the main point they make is there aren't any anymore. Perhaps they make that point because, well, you have to cover everything. But DOs, which were talked about a lot in Chapter 4 about providers, are generalist. And, well, they're not always generalists, but they tend to go towards generalist occupations because they are trained as generalists, right? And so they then had to set up their own hospitals because remember that beef they had in the late 1800s with the allopathic MDs, and since then, like, they patched it up a long time ago, but they had created this other infrastructure. Well, it turns out that other infrastructure in 1970, for instance, osteopathic hospitals were finally eligible to apply for registration with the AMA. Well, if they've been discriminated against by the AMA for good or bad reasons, they obviously weren't doing very well, right? Because the AMA is pretty powerful. And since then, allopathic and osteopathic MDs and DOs practice side by side in clinics and hospitals, so you really don't need special hospitals for them. And so today, you really don't have them, and they're just community general hospitals. Like if there are any, they have become indistinguishable from the community general hospitals. MDs and DOs are integrated, and ultimately, it was found that non-osteopathic hospitals were uh, less costly. Like I say in my third point here, the osteopathic hospitals were found to be more costly and less productive than their counterpart non-osteopathic hospitals. I'm not exactly sure why. I didn't read the research, and then many have closed anyway. So, your book gives a shout out to osteopathic hospitals, but I think they're giving more a shout out to DOs, because DOs can still practice in our hospitals now, no problem. They can bring their approach to the population, and so let's see what happens with that. Let's hope there are more. So let's look at hospital employment. Okay, so look at the yellow bar. That talks about 2000 to 2010. And then the red bar is sort of weird because it's a projected one. It's 2008 to 2016, right? So this is, again, rate of growth, right? Remember I go on and on about the rate versus the rate of growth. This is rate of hospital employment growth. So if you look at 2000 to 2010, which already happened, so we know what it is, you have that whatever it was in 2000, right? However many people were employed, it was 18% higher in 2010. So in 2010, the U.S. healthcare sector employed 16.4 million workers. That's a lot of people. So 4.7 of these, so about 5%, were in hospitals. Or 4.7 million of these in the hospital, so it's 29%, which is almost a third. So as you can see, that's like almost a third of the U.S. healthcare workforce, which is pretty big in 2010, was actually employed in hospitals, even though we have a big outpatient structure. But that rate can't grow at that high of a rate, right? So we have 12% is the projected growth. So if you're looking for a job or training for a job in the healthcare system, I wouldn't target hospitals. You might work on one that closes or whatever. I don't know what they're going to do. I mean, they need to do something about hospitals, but I would target somewhere in the outpatient sector because I'm not sure that that's really going to work out much as well as it has been. So let's look at these types of hospitals, and how this is categorized makes it a little challenging to talk about because, of course, they have all these different characteristics and it's hard to really understand them because, like, if you look at that 4% that's federal, we're thinking the VA, and then when you look at the private nonprofit, which is 50%, and then the private for-profit, which is 17%, that 50% and that 17% are really very similar, but then you have the state and local governments, which are 19%. And a lot of times we can't, as patients, can't tell the difference between which one we're at by how they're acting. Like, they don't advertise this stuff. And then this other non-federal that says at the bottom of the slide are mostly non-federal psychiatric and long-term hospitals. But as you can see, in this way of counting hospitals in 2009, 50% of them were private nonprofit. So they're supposed to be investing their profits back into themselves and thus the community. And 17% are private for-profit. There's been this trend towards privatization because these nonprofits can't stay alive. Let's see if this pie changes. So now we get to the local scene. Hospitals in Massachusetts. So if you live where I do, this is the local scene. The reason I wanted to give some real examples is because it's a little easier to see all the attributes at once of a hospital so you can weigh it out in your mind. This slide just simply lists all the different attributes there are. You'll see on the left side of the slide you got general, and then on the right it's specialty, and if it is specialty you have to classify it under those, right? Left you've got public, and then on the right you've got private. If you've got public it could be for-profit or non-profit, but if it's private it could also do that. But on public side you also got the community versus not community to deal with. Allopathic versus osteopathic is a little more obvious, and then teaching versus not teaching. Well, if you're teaching hospital, you have these other classifications, and then urban versus rural, so they can be a mix and match. Let's start with Emerson Hospital in Concord, Mass. What kind of hospital is that? Let's look at the slide. First, it's a general hospital. It's not a specialty hospital. It doesn't specialize in psychiatric or rehab or children's. Next, it's a public hospital. It's community. It's also nonprofit. For all these hospitals, I went to their webpage, and that's what I learned what they were. It's an allopathic hospital. This is likely to be because there's not many osteopathic. It's not a teaching hospital, and it's urban. It's considered urban. People who live in Concord might not agree with that designation because there are some sort of semi-remote areas, but it is, overshadowed by the MSA of Boston, so it's considered urban. Newton-Wellesley Hospital, I have mentioned several times, so you can take a look at this and make your guesses. here we are. Newton-Wellesley is general, and we should imagine that because we know that it lets all kinds of people in for all kinds of reasons, not just psych, rehab, and children's. It's public, it's community, and it's also for profit. What's interesting, and it's an allopathic hospital, and it's a for-profit teaching hospital. It's a major teaching hospital, although it doesn't have an academic medical center. And it's urban. Well, that's interesting. It's a for-profit teaching hospital. Spaulding Rehabilitation Center in Boston, Mass. is a place where a lot of people have gone if you live in Boston and you need to rehab for a while. And this is the kind of like physical rehab, not like, like if you fall off the wagon. So what happens here? Well, this is that rehab specialty, right? And this is actually a private nonprofit, so it's not public. And so it's an allopathic, it doesn't follow osteopathic approaches, and it's actually a teaching hospital. So if you study rehabilitation, you may find yourself in Boston having some work at Spaulding Rehabilitation Center. And of course, it's in Boston, so it's urban. There are many different types of hospitals with many mixes of characteristics. Each type of hospital plays a unique role in the U.S. healthcare system, but for different reasons, some type of hospitals are more common than others, and historical and current pressures cause certain types of hospitals to close in some areas where other types are favored. Hospitals will continue to evolve, and let's hope enough of them stay open so they can play an important role in the future of the U.S. healthcare system. Now we have reached the end of Chapter 8, both lectures. At the end of the second half lecture, you should be able to describe at least 2 ways to classify hospitals into types, name a real hospital from the lecture or from your own experience, and know how to classify it into a type of hospital. Describe 1 way a nonprofit hospital is different than a for-profit hospital. And finally, you should be able to give an example of a specialty hospital. Now that you better understand how to classify hospitals, you should be asking yourself some questions. Aren't there some contradictions in there? Is there some contradiction for the government owning something that is a private industry? Is there some contradiction for a religious organization owning a hospital where people who are not of that religion are going? Hopefully all of these questions have been brought up in your mind, and you can ponder them as we move forward into the U.S. healthcare system.